Ladies and gentlemen, my name is Dr. Frank Lepeg, and I am a member and the Secretary General of the CIMS, the French Musculoskeletal Imaging Society. I'm going to talk to you about my experience of US guided pulley release of trigger finger. And I will start with the diagnosis with all the classic clinical and ultrasound signs of trigger fingers. But I will also discuss lesser known signs and trigger fingers not related to flexor tendon impingement, which you will not be able to treat without technique. Trigger finger is a very common condition. 2.6% of people will be affected in their lifetime. The frequency is 5 to 10 higher for diabetics or for people who have carpal tunnel surgery. Thumb and ring finger are the most affected. This pathology is related to a mismatch between the side of the flexor tendons and the A1 pulley. Exactly here in the area colored in red. The mechanical conflict in the critical zone leads to thickening or even metaplasia of the A1 pulley, but also to the thickening of flexor tendons and especially the flexor superficialis. Clinical findings. We have described 4 grades of trigger finger. First one, the triggering is intermittent and moderate. The second one, the triggering is continuous but eliminated with an active extension, like in this example.
Allez, je plie à fond. Là, ça y est, il est bloqué. Et là, ça y est, il a débloqué un peu. Voilà, parce que plus je le fais, après...
Refaites. Après,
allez,
quand vous le refaites...
Ça va mieux.
Ça va mieux.
Ah!
For the grade 3, triggering requires the patient to use the other hand to unlock the involved finger.
Allez-y.
Vous voulez que je le recoince?
Ouais.
Oh, vous êtes méchant là.
Décoincez.
And for the grade 4, flexion is impossible.
Fléchissez la main. Fléchissez le doigt. Allez-y. Allez-y au maximum. Faites ce que vous pouvez. Le maximum. Vous êtes à fond là? Laissez-moi faire. Ok, relâchez.
Here is an example of grade 4 on the right finger of the thumb of a little girl.
Plie. Plie les pouces. Étends. Plie. T'es à fond là.
Now I will describe the signs listed in the medical literature. The first one is an hypoechoic thickening of the A1 pulley in 100% of cases in the paper of Henri Guérini. The pathological pulley is in the red square and the normal pulley in the green square. Sometimes the thickening could be nodular or with some cysts. The cyst is colored in red. Another sign is the hypervascularization of the A1 pulley in 91% of cases. Tenosynovitis could be observed in 55% of cases. In red, you can see the tendons, and with the white arrows, the A1 pulley. Now let's talk about tendinosis. A tendinosis in the form of hypoechoic focal tendon thickening could be observed in half of cases distal to A1 pulley. Usually triggering is not directly visible because of the volume of the probe. You can see here the nodule of tendinosis trying to slide under A1 pulley. The last sign is the dark sign of Gruber. It's right here, especially for the thumb. This is an anisotropy artifact due to the change of direction of the tendon fibers under the hypertrophic A1 play. But not everything is written in books and papers, and here are some signs from our experience. In this case of a real triggering, the A1 play is normal, 0.6 mm, but you can see other signs. For example, this nodule of tendinosis in red. Another sign is the asynchronism between the deep flexor and the superficial flexor. You can see here the deep flexor sliding well, whereas the superficial flexor that not slide well. In our experience, the surface area of the pathological tendon of the finger 2 to 4 is greater than 30 square millimeters. The flexor superficialis is thickener and the place of tendinosis. In rare cases, in addition to blockage under A1, we observed an inability of tendons to slide under A2 with flexion of the pip joint. The marked thickening of the tendon explains the conflict with play A1, but also with A2 during the extension. Here is a clinical video.
Donc là, on a du mal à étendre votre doigt. Hein. Cette articulation-là ne s'étend pas.
And the corresponding ultrasound image. Note the significant increase in flexor tendon surface area, 44 square millimeters. In red, here are the superficial flexor tendon bands. Surgical treatment is a resection of a lateral band according to Leviat technique. Here is a video showing the intraoperative result. I will now tell you about differential diagnosis. In the following cases, this is not a conflict between A1 and flexor tendons. First differential diagnosis, Dupuytren's disease of the fifth finger. Here are the MRI and ultrasound scans. Here the fibrous cord of Dupuytren is colored in orange, and under the green arrow, this is a flexor tendon.
Essayez de fléchir.
Swan-like deformity, in this case secondary to a mallet finger, can cause an atypical triggering, like in this video.
Essayez de fléchir. Fléchissez. Ok. Relâchez. Fléchissez. Relâchez. Allez, pliez.
In this case of an 84-year-old man, the atypical triggering is due to a swan-like deformity secondary to osteoarthritis. The triggering increased after surgical resection of A1 and after the resection of a lateral
Allez,
band.
Pliez. Relâchez.
The correct treatment is different. The hyperextension of the pip joint must be counteracted by attaching a lateral band of the extensor to the lateral band of the flexor superficialis. Here is the clinical finding before surgery in A and the results after surgery in B and C. For the second part, a tutorial on my tips, you can see the next video.